Okay, now we're recording. Now you can
Thank you.
start your presentation, start your share screen, and I'll introduce the speakers and start the session formally. There it is. So hello everyone, this is CPD webinar series, global medical education webinar series, organized by the alumni of Dow Medical Colleges. And we have changed the name slightly to encourage more global participation. We are already very global, but to make it very formal, we decided to slightly change the name to something more international and more global. So the format is exactly the same. We have two speakers and there are 20 minutes talk on various topics. Usually we discuss relevant to general practice, general medicine, for internist, hospitalist, whatever you call them. And at the end of the talks, there is an opportunity to ask questions. My name is Dr. Naseem Naqvi. I am a consultant stroke physician in Blackpool in England. And my colleague, the program coordinator, is Dr. Mansoor Ali. He is a consultant renal physician in England, in Yorkshire. So let's start our session. Now, all of you are muted, but as I said, if you have any questions, you can post the questions in the chat box. So today we have two very interesting talks, very relevant. The first one is on the association and correlation of COVID-19 for maternal deaths, for maternal mortality, pregnancy, very important topic. I will hand over to my colleague, Dr. Anira Shakir, who is the specialist registrar in Obstetrics in London. So over to you, Anira. Thank you.
Okay, thank you very much, Naseem and Mansoor, for giving me the opportunity to talk on this very important and heartfelt topic, being heartfelt and close to my heart, pertaining to the fact that I joined NHS at the very same time in which this report was released, that is in March 2020. And I had myself witnessed the challenges that the NHS has gone through in dealing with such unprecedented times, and the various messages that have been learned over the time and during this current second wave, what we have been experiencing so far and what we have come out as so far. So here's the report on the maternal and let me just start the slideshow. Yeah, on the mothers and the babies, reducing the risk through audits and confidential inquiries across the UK. It's a triennial report, and that's done by collaboration of the National Audit Programme. And this was a rapid report that was released on August 2020, and that really highlighted the messages that have been learned through the SARS-CoV-related and associated maternal deaths in the UK during the period of 1st of March 2020 till 31st of May 2020. So the main idea behind this report was to learn the impact of the infection that it had on the pregnant and the postnatal women, as well as identifying the lessons learned to guide any future care and proposed NHS changes that we see. The funding's been provided, as I just mentioned, by the National Clinical Audit and Patient Outcome Programme to the Maternal, Newborn and Infant Clinical Outcome Review Programme, and those who commissioned MEBRACE. And the stakeholders being the NHS England, NHS Wales, the Health and Social Care Division of Scottish Government and the Northern Ireland Department of Health. The various programs can be accessed through the HTTP address thereby. The methods used had been quite different from the standard Embrace UK methodology that they employ every 3 years. This being unprecedented times, unequalated times, so direct reports from staff at the hospital where the woman died were also included. And I must say the first COVID-related pregnant woman being reported from our own hospital at North Middlesex, London. That was, I mean, it was not, it was those times when it wasn't a straightforward cutting edge or on the spot diagnosis of a COVID lady, but then it was suspected COVID, which later turned out to be positive, and it was on the media the very next day or the day after. So there had been media reports that had been collected over the time, and the Northern Ireland Maternal and Child Health Team reports, the death registrations in Scotland as well during the same time period, as well as a UCOS study of the women who were hospitalized with SARS-CoV infection, and that also serves as a KPI indicator for our triennial reporting throughout the time of audit. And the HC branch, which looks into any suspicious or investigation requiring deaths of the women. And lastly, the virtual MDT chapter writing meeting was conducted after collaborating and collecting all the data from all these different resources and then putting them into this report. Coming on to the report, the women who died, there had been 10 women reported who had died with SARS-CoV between the 1st of March and the 31st of May. That's a 3 month time period. Now, these have been variously categorized into different category of women, as you would see in the following slides as well. The 9 women with the SARS-CoV infection died during or up to 6 weeks after pregnancy, while 1 died after delivery or 6 weeks to 1 year at the end of pregnancy. 8 of importance is that in 8 women who died from the COVID were in the 3rd trimester of their pregnancy at the time of the disease onset, and subsequently 1 of them died after she gave birth. 7 women, including the woman who died in the late postpartum period, they died directly from the causes relating to the COVID-19, rather than having other comorbidities like diabetes, hypertension, or preeclampsia. That just shows the lethality of the infection. 4 women died by suicide, sadly, as well, and 2 of them were still pregnant at the time of their deaths, while 2 had already given birth. And 2 women died as a result of domestic violence, both between the 6 weeks and 1 year after the end of the pregnancy, and that being mainly due to the lockdown major issues in which women couldn't be assessed for safeguarding purposes, or even they were themselves afraid, or they didn't know or had no idea where to go to. So overall, if we calculate all these sad stories, then the women who died had 18 children from the previous births, and thus a total of 30 motherless children still remain. If you come to statistics, the number per 100,000 between the same time period, over 160,000 women gave birth in the UK, and that gave an estimated SARS-CoV associated maternal death rate of around 6 per 100,000, or a MMR of 6.2 per 100,000. And at the same time, the suicide rate during the same time period went up to 2.5 per 100,000, or just over 2. And the mortality due to the domestic violence or the murder during up to 1 year after the pregnancy came up to 1.2 per 100,000. So the death rates in the standard embrace reports are reported over 3 years' time. Therefore, these death rates might not substantially reflect what the remaining year or the yearly report or triennial report, whatever form it comes out to be. But it does show that it has a significant impact on the overall mortality. The demographics that have been projected on the report, it shows different socioeconomic demographics as well as parity. Body mass index being highlighted in a non-pregnant population as the obese being more predisposed to the COVID-19. But in this context, if you see that for pregnant ladies, those at the lower side of BMI, the percentage was 50% of them meeting that, while more than 30 or the morbidly obese being 19%. So it was varied. The ethnicity, as we'll see in the coming slides, also highlighted the fact that the BAME community women have been highly affected. And the report says about 88% of them were of BAME ethnicity. And about 56% of them, the region of birth, though, was in the United Kingdom, while a vast majority had come from the Europe and the Asian background. So these are the existing guidance and recommendations which had required certain improvement and implementations, which I won't go at this point owing to the lack of time. And we were seeing each and every lesson learned and what changes had been implemented in relation to these guidances. So as to summarize, the key points and recommendations would be a substantial inequalities remain for Black, Asian, and minority ethnic ladies. That's about 88%, as I mentioned. Third trimester of pregnancy being a high hotspot for the COVID-19 infection itself. And it has overtaken the period of postpartum that's been highly thrombotic itself. So the key recommendation in this regard was a better joint appear, not only from the midwives, but from the physicians as well as the obstetricians and the intensivists. The perinatal mental health services to be actively involved in the care of such women, as mental health issues have prevailed vastly over the time of the pandemic. And all women should be considered for antiviral or other specific therapies for the COVID-19. For this, the recovery trial that can be found on this HTTP is actively promoting inclusion of pregnant women for both pregnant as well as postpartum and for experimental therapies like remdesivir, tezolizumab, and it's been commissioned by the MHRA and the early access of medicine schemes for severely ill or critically ill hospitalized patients. So we are actively encouraged to enroll our women who have been diagnosed with COVID-19 to enroll them in such trials after informed consent. Women with the other recommendations that women with COVID-19 should receive information on their risk of deterioration and when to seek urgent medical attention or go to the hospital. Interpreting services should be used when necessary, and this emphasizes the fact that in high-risk areas like our trust, in which 80% of the population is non-English speaking, then such services are mandatory in order to convey the message of safeguarding as well as red flags. In the absence of a vaccine, prevention must remain the goal of any public health issue, and that being the social distancing, wearing masks, hand hygiene. Ensuring good communication with partners and families is maintained, and facilitation of visits between critically ill women and their partners is also emphasized, though it was not practiced throughout the pandemic. And we had the sad stories of women and people dying in the ITU as well as on the wards and different areas and not being able to see their loved ones at the end. But this is one of the crucial points that need to be mitigated in the current second wave of the pandemic and any other anticipated waves. There is always a need of more specialist midwifery roles for vulnerable women who would fall in any of these categories. As you can see, the perinatal mental health or obesity, asylum seekers, and traveler women who would need extra vigilance and extra specialist midwifery care, for which the Royal College of Midwives and the Royal College of Obstetricians and Gynecologists are collaborating actively on. Now it comes to the series of short, sad stories that and the messages of care for these women who we have seen over this period of time that was a peak of the pandemic. The first message learned was that for a senior obstetric review. So the story of the woman goes that a woman in her third trimester of pregnancy presented to the ED a week after symptoms of COVID-19, but her observations were just documented using the news chart and not on the Muse chart. That's a modified early obstetric warning scoring system. She had a respiratory rate of 36, but this was not recognized as significant. And her first review was also delayed by the obstetric staff by 11 hours, and a junior obstetrician unfortunately identified no obstetric concerns. She deteriorated a few days later and was documented to need high HDU or ICU care, but no beds were available, and sadly on either the HDU or ICU areas. Her care was discussed with the consultant obstetrician at the time of her deterioration, and a decision of cesarean section was made. Following her birth, again the same problem of no beds, she was transferred back to a general ward where she deteriorated again, was intubated, transferred to the intensive care, worsened, and died a few days later. So this woman clearly points towards, the care of this woman would point towards the fact that she was cared in 5 different settings with no idea of who was exactly looking after her. And the obstetric staff being involved with the junior staff, and no senior input was taken till it was quite late and a time of delivery or cesarean section was made. In fact, after the cesarean section, it was found that it had documented no further obstetric review. So in this context, the importance of our modified obstetric early warning system or scoring is more emphasized than the regular news key, and the involvement of the senior decision making by the colleagues, as is reported in the previous reports of Saving Mother's Life, as well as the RCOG guidelines in the previous issues. The critical care in the temporarily repurposed settings, such as the operating theaters or recovery areas, was identified as one of the main problems in such cases. The staff redeployment who were unfamiliar with the critical care equipment, including ventilatory support, and with no prior experience of having to care for any pregnant or postpartum women, was another major factor. And I myself, per se, have seen this happening with our junior SHOs while during the pandemic, who had been assigned to ITUs and had never worked in ITUs, and our ST1-2s and ST1 and 2s even in obstetrics gynaes, and going back to the ITU, where they were just not as dexterous with the skills needed as they were when they were doing the FI1s or FI2s. So very minimal training, and it just led to inevitable errors. So the recommendation now is to attention to skills and knowledge and supervision is needed when acute settings are staffed with those unfamiliar with the area. And a minimal time of orientation has to be implemented or has to be given before the working in a new clinical environment. So in this context, I would say, the other lesson learned was the location of care. And which was also, as we just said, that it was just most of the care was provided in a temporary setup. While the location of care, a woman in the another story goes for a woman in the third trimester of pregnancy who was admitted with a weak history of COVID-19 symptoms. And this lady remained in the ED for several hours again and was assessed as having mild to moderate COVID symptoms by medical staff. It was recorded that she did not have any evidence of respiratory failure, though she was hyperventilating, and her respiratory rate of with a respiratory rate of 70 overnight and an oxygen saturation of 94% on 4 liters of oxygen at the time when a decision for cesarean birth was taken. She improved initially, but subsequently died. So the severity of the woman's condition was not recognized, of course, clearly by the staff who were not familiar with caring for the pregnant or postpartum woman. And several women had metabolic acidosis, the significance of which was overlooked. And this is very much significant in the case of a pregnant woman and those with comorbidities like diabetes. And this happens in our usual everyday practice as well. The decision for iatrogenic birth, which was often delayed because of midwifery or obstetric input. And even when the decision was made, it was sadly made by a junior staff rather than a senior consultant obstetrician. Induction of labor as opposed to cesarean delivery, even for multiparous women who have had previous uncomplicated births, was not considered as a first-line option. And rather, it was always resorted to cesarean section, which itself carries a high morbidity. So in this context, I would say that our hospital, our trust had pioneered in making the emergency maternity rearrangements during the pandemic, with all the elective cesarean workload being transported to the Portland Hospital, which had the famous names of Meghan Markle and Prince Archie being born there, and the patients accepting this alternate arrangement with whole heart and with full satisfactions. And where we recently are in the second wave of the pandemic, we have utilized the services at the Highgate Private Hospital for our elective gynecological workload. And this has been going smoothly and streamlined so far. So these arrangements go in line with the previous maternal reports, critical care guidelines, that critical care support can be initiated in a variety of settings, and signs of decompensation, red flags should always be highlighted in whatever setting the woman presents. And this goes in line with the RCM as well as RCOG guidelines as well. Then came the very famous collaboration in a context with the location of care, being the NHS, who proudly collaborated with the Tottenham Hospice, and all our antenatal care being shifted in the clinical setup to the stadium. This was again welcomed very much so by the antenatal population, and we had a record number of antenatal visits during that time of the pandemic. Well, of course, there were so many attractions outside and inside the stadium as well, and women, after getting over with the appointments, would just be found doing a lot of activities. So this generated a lot of interest in public as well as social media being highlighted on various channels. And this is one of the strategies which could re-implement in coming days of the pandemic, should it reach to those levels as well. As you can see, this was the locker room of the Tottenham Hotspurs, and that being converted into our convertible CTG monitors and operation stretchers, as well as scanning machines. And this was the luxurious waiting area outside, where the women would wait for their chance but would not be furious or grumpy. The second important lesson learned was prevention and management of thromboembolism, since COVID-19 was found out to be a highly procoagulant state. And for this, the ongoing trial of REMAP CAP is being instituted, in which there's a randomization to standard thromboprophylaxis versus the therapeutic anticoagulation is being studied. So some of the centers, they have argued on giving higher dose of thromboprophylaxis, even as prophylaxis, thromboprophylaxis, as opposed to the regular thromboprophylaxis, or the treatment doses as opposed to the therapeutic, as opposed to the preventive doses being for the COVID positive cases. Because there had been reports again of a postpartum woman who appeared to be recovering after intensive care and suddenly deteriorated with a headache and a blurred vision. And a CT scan showed brain ischemia, artery thrombosis, from which she died. Now, this could have been underlying ischemia or a stroke, or it could be COVID related itself. The report doesn't elaborate much on that. A second woman, also in the postpartum, deteriorated very suddenly after a few days whilst in ITU, and which may have been due to a thrombotic event. So thromboprophylaxis is quite mandatory, it's quite essential, and cannot be overemphasized anymore. This goes in line with the RCOG COVID guidelines that had been over-stressing the fact that the VTE risk assessment should be done for all the pregnant women, and pregnant women admitted with confirmed or suspected COVID-19 should have the low molecular weight heparin received prophylactically unless the birth is expected in 12 hours of time. And MDT review should be conducted for women who have higher risk factors, and a further 10 days of course of thromboprophylaxis should be constituted for women following hospital discharge. And for women with persistent morbidity, even considering a longer course of the anticoagulation can be considered. If the women are admitted with confirmed or suspected COVID-19 within 6 weeks postpartum, they should again use thromboprophylaxis for the duration of their admission, as well as 10 days post-discharge, again extending this to 6 weeks postpartum if any ongoing morbidity arises. The other lesson important enough in public interest was the advice to stay at home or self-isolate. Now, this was clearly found to be overemphasized, as women were found just too eager not to come to the, either to get advice while not coming to the hospital, being scared, or being just going over-the-counter drugs and taking them in highly toxic doses. Even paracetamol toxicity had been reported in one of the cases. So in this report, it highlights that 3 women died at home or presented to the hospital late, either because of reluctance to attend or fear of infection, or due to following the stay at home advice, which was just overemphasized. So in this report, the RCP toolkit for acutely ill pregnant women, it's been highlighted, which would highlight the red flags of breathlessness to be aware of. And this goes in the context of general public awareness, the sudden onset of breathlessness or topnia, any tachycardia, respiratory rate of above 20, and oxygen saturations of less than 94%, or falling to less than 94% upon exertions, and associated tachycardia, all being red flag, and to be reported straight away to the triage, and even to be presented to the maternity triage itself, as in physical. There has been certain good points that have been highlighted in the report as well, though with sad outcomes. But for the streamlining and for the encouragement of the staff, The story goes on of a woman in the third trimester of pregnancy with breathlessness. So she was seen in ED and COVID-19 was suspected. Swab was taken. She was advised to self-isolate and advice was given to return if the symptoms worsened, which she did 2 days later. She was appropriately rapidly referred to obstetric team and admitted to labor ward for observation. She improved slightly, but then a decision for cesarean birth was again taken to aid her respiratory condition. She had a regional anesthesia, was able to see her baby. Postnatally, she began to deteriorate. Her care was appropriately escalated intensive care and respiratory medicine review before she was intubated again and admitted to ITU. Unfortunately, despite high quality intensive care, she died. But this case scenario, it clearly depicts the safety netting that was done for this lady and the effective communication that existed between the different entities that is crucial to good care.
Anila, you have 1 more minute.
Okay, so I'll just go through the messages for the mental health care that have been highlighted proficiently in this report, that the postnatal woman with mental health problems contacted her GP several times, and she was just prescribed a higher dose of antidepressant. She had contacted crisis team, which who regarded her as not being suicidal, and she was referred again to perinatal mental health team and again the crisis team, but nowhere was further face-to-face consultation was done, and she was always advised over the phone, and she died by suicide the following day. So this highlights the establishment of triage for assessing to ensure that the women with health concerns have been seen appropriately. And in red flag situations where constant or continuous referrals with the mental health concerns is being done, then it should be mitigated as face-to-face no matter what. This has gone in the previous highlights as well. And the woman who died as a result of domestic violence, the woman with multiple disadvantages had been reporting herself to have a violent partner, but no considerations appear to have been made around the protection of the woman herself. And she died of a violent assault a few months postpartum during the lockdown period. Second postpartum woman had to see the same fate on part of her violent partner, though she had informed her healthcare visitor, and all the same, she was never, nor she or nor her children were moved to a place of safety, and she was killed the following day. So all this updated guidance it will reflect the safeguarding issues and including a removal to a place of safety if necessary. And this has been highlighted in previous issues. So just my last slide, the classification of care that was received by these women from the SARS-CoV. If you see statistically, then in about 1/3 of the cases, they could have been room for improvement for women who died of SARS-CoV virus. And about half of these women, or 50% of these women, for those dying due to homicide or suicide, they could have substantially improved had the right care been met. While the good care was provided in a very few subset of these women. So it necessarily highlights the importance of having to mitigate the stakeholders and to take the key messages from this report and implement the necessary changes all through. Thank you very much for your attention.
Mansoor? Sorry, hang on. Okay, Mansoor, go ahead.
Thank you very much, Anila, for that. That was an excellent presentation. I'm sure there'll be lots of questions that will be asked. We'll go through that in a short while. I just wanted to kind of actually apologize to everyone involved here, especially the audience. We had an emergency with the second presenter. Unfortunately, the second presenter, Dr. Yawar Saeed, could not join us from Pakistan. I'm really sorry about that. I know a lot of you would have actually wanted to go through the ECGs with Dr. Yawar Saeed. I hope he's okay, and we'll get to hear from him soon. But got my colleague, my co-chair, Dr. Naseem Naqvi, who could present to us on stroke. Something is actually presented to the smaller audience about a few months ago. So once again, apologies from both my end and Dr. Naseem Naqvi, but you've got Dr. Naseem Naqvi's stroke presentation. So Naseem, over to you.
Okay, very good. Thank you. Can you all hear me?
Yeah.
Okay, very good, excellent. So very quickly, so I'm a stroke physician in the NHS, and I'm going to give you very quickly a quick overview of acute stroke. What you need to know. Now, a stroke is very common. Every 2 to 3 seconds, someone suffers a stroke in the world, and more than half do not make a full recovery. And about one fifth of the patients need some help with care. So stroke has significant morbidity, mortality, and it is very, very important to get a good understanding of acute stroke. Now, when I am on call for a stroke, I go through this list of 7 questions. Okay. Now, the first question is this a stroke or a TIE or some form of cerebrovascular event? Because there are many stroke mimics, as you know. For example, things like hypoglycemia, things like brain tumors, sepsis, and so on. So the first question is this a stroke or is this a stroke mimic? Sometimes the differentiation is not that easy. It can be difficult. The second question is that which part of the brain is affected? Okay, so this is a stroke. Which part of the brain is affected? The third one is which arterial territory is involved? Is this anterior circulation, posterior circulation? And then does it fit into some kind of a recognizable clinical syndrome? And there are only 4, which I'm going to talk about in a second. And then what type of event is it? Is this a bleed or is this an infarct? And what could have caused this pathology? For example, things like high blood pressure, in young patients, sometimes vasospasm due to drugs, cocaine, etc. And then what might be the functional consequences of this presentation? So as you all know, the definition of stroke is that it's a vascular disease. It's a neurovascular syndrome, usually resulting in focal neurological signs, sometimes global, such as subarachnoid hemorrhage, etc. But usually the symptoms last longer, and patient sometimes end up with significant disability, sometimes mild disability, but usually symptoms last much longer and there's a permanent damage. And it's a vascular origin, so it's a vascular disease. The second question is which part of the brain is affected? We know this from our basic medical school, our basic anatomy. Some of you might remember. You may have seen this recently or in the books. This is a homunculus, okay? And this is basically what it is. It is representing is an unequal representation of the cerebrum, the cerebral cortex, to how it supplies the various parts of the body. As you can see, the thumb, the face, the lips, that part of the body unequally represented as compared to some other parts. So which means that you're more than likely to suffer a loss of power, sensations to these parts of the body because of the way the brain sees them. And they are very important. Hand is important, mouth is important, eyes, face. So which part? The next question is which arterial territory is involved? I think it's important to have a very basic understanding of circle of Willis, but if you can't remember it, it's fine. But it's basically a combination of anterior and posterior circulation. So the anterior circulation are 2 internal carotid arteries that they are in your neck, and as they go up and enter your brain, they become middle cerebral arteries. Okay, so just remember this. You have common carotid artery, yeah, and then you have 2 branches: external carotid, which supplies the face, and the internal carotid, which we are interested in as stroke physicians, because it enters the brain, and it enters the brain and becomes middle cerebral artery. And then the posterior circulation, you have 2 vertebral arteries in your neck, and they go up, and at the base of the brain, they join to form a basilar artery. As the name suggests, base of the brain, basilar. There's only one artery, the basilar artery, very important. And then basilar artery gives 2 branches: posterior cerebral artery, 1 on each side. And this is your circle of Willis. Okay, so anterior circulation, internal carotids; posterior circulation, vertebro-basilar circulation. The the next question is this a recognizable clinical syndrome? As I was saying earlier, there are 4 types of strokes, and you may have seen these in the on your general medical wards. Stroke patients, doctors writing TACs, PACs. What is it? Okay, this is easy. There are only 4 types according to this OCSP classification, which is Oxfordshire Community Stroke Project, also called Bamford classification. John Bamford, a stroke physician, a stroke professor, working in Yorkshire. And this is easy to remember. Okay, so there are 4 types. There is total anterior circulation stroke or syndrome. There is partial anterior circulation syndrome, lacunar syndrome, and posterior circulation syndrome. Now, you notice that I use the word syndrome and not infarct, because a stroke is a clinical diagnosis. You make a diagnosis of a stroke on the basis of symptoms when the patient presents. So the stroke, you don't need a CT scan or any scan to diagnose that the patient is having a stroke. So stroke is a clinical syndrome. Why are you doing the CT scan? To rule out whether it's a bleed or a ischemic stroke, and also whether this is some kind of a stroke mimic, for example, a brain tumor and things like that. So when the patient first presents, you can just assess the patient, examine the patient, and then you can write whether this patient has TACs, PACs, LACs, or POCs. S for stroke, S for syndrome. Now, once you have done the scan, and let's say there is a bleed, and it is involving the total anterior circulation area, then the nomenclature changes and the TACs becomes TACH. TACs becomes TACH, total anterior circulation hemorrhage. If it's an infarct, it becomes TACHY, total anterior circulation infarct. PACs becomes PATCH, TACHY. LACs becomes LACs, LACH, LACHY. Okay, so you got it. Now, what is this? Very easy. If you have homonymous hemianopia, unilateral weakness, and higher cortical dysfunction. When I say higher cortical dysfunction, I mean dysphagia, apraxia, and all those things. Then you have TACs. So you have to have all 3 present. In partial anterior circulation syndrome, any 2 of the 3 will make it PACs. So if you see somebody has got a diagnosis of PACs written in the medical notes, right-sided PACs, what does that mean? First of all, it's the right side of the brain that we are referring to, not right side of the body. Please understand this. I see this mistake, very common. Junior doctors write right PACs, patient has right-sided weakness. No. Right PACs will cause left-sided weakness. Please understand this. So this classification is the part of the brain affected, not the part of the body affected. Please, first of all, understand this. Now, so the right PACs will cause left-sided weakness. So in PACs, you have to have any 2 of the 3 present, which is hemianopia, weakness, and higher cortical dysfunction, which means dysphagia. So if you have a patient who is dysphasic, so you're seeing this patient in A&E, he can't speak, he has got right-sided weakness, and he's partially blind in the eyes. What is it? It's TACs. You have diagnosed TACs without doing a CT scan or MRI scan or any scan. You have got right-sided weakness, you've got hemianopia, patient can't speak. That's TACs. Okay. If you have any 2 of these 3 present, so you have left arm weakness, you have a patient who has some dysphagia, but eyes are all right, then the patient has PACs. So understand the difference. Lacunar syndrome is when you have unilateral sensory or motor deficit. You may have seen those patients, just one half of the body, doctor, I can't feel anything. That's usually a lacunar syndrome involving the deep arteries in the brain. And the POCs is the posterior circulation syndrome, which involves your vertebrobasilar circulation. You remember from the circle of Willis. So this is the part of a brain stem midbrain pons, medulla, cerebellum. Okay, so I hope that's clear. So if you have a patient with cranial nerve palsies, ataxia, brain stem signs, they have POX. Okay. So this is what a hemianopia looks like. This is somebody who's seeing. So if I'm seeing this, so let's say my right eye, close your right eye whilst you're seeing my slide. Close your right eye. If you see something like this patient has left homonymous hemianopia. Well, we don't know what is homonymous because you have not tested the right eye, but usually it's homonymous. So it's the whichever side the temporal field is gone, that side is the hemianopia. So remember this. So junior doctor always asks me, Dr. Naqvi, is this right homonymous hemianopia or left? Remember, if your left temporal is gone, so if you're looking at my screen right now, close your right eye, you can see that the left side is black. The medial side, I can see some. Temporal side, I can't see. I have got left hemianopia. And if on the other side, cover your left eye now, and if the right eye you see the right medial is gone, but the right temporal is all right, then that makes a complete picture. Got it? So this is what it looks like when you ask the patient to cover eyes. So it looks like this. If you're seeing the field, left temporal is gone, right nasal is gone, left temporal, left homonymous hemianopia. Okay. So if I'm seeing this field and my left temporal is blank and right nasal is blank, then it's left homonymous hemianopia. So this is a CT scan. I'm going to wrap up quickly. Black means that's the infarcted area. And it's usually a sign that the stroke is quite well established. In the early, very, very early stages, sometimes you don't see any changes at all. And that's why I'm saying that a stroke is a clinical diagnosis. In fact, if you want to thrombolize and patient has a completely normal scan, it's actually you should go ahead and thrombolize, because if you see a very well established large dark area, it may suggest that actually the stroke happened good few hours ago, and maybe the part of the brain is not salvageable. Remember that in Lacunar syndrome, there is no visual field deficit and there is no dysphasia. There's no higher cortical dysfunction. So how do you differentiate lax with pax? So in pax, you often see visual field deficit, higher cortical dysfunction, dysphagia. In lax, the only thing you see is hemisensory or hemimotor signs. POX is posterior circulation. This is another scan showing posterior cerebral artery infarction. Most of them are infarcts, some are hemorrhages. We know the causes of hemorrhages: hypertension, anticoagulation. Bleed looks white, as you can see on this scan. This is another scan showing subarachnoid hemorrhage. Now, I'm going to go through quickly. I want to show you this very important slide and then I'll finish. A stroke unit is important to admit patient on a stroke unit if you have one in hospital, because this is a specialized unit. Patients are monitored, they are treated according to the best practice guidelines, and the evidence shows that for every 100 patients treated in a stroke unit, 3 fewer patients will die, 3 fewer will require institutional care, which means nursing home, care home, and 6 more will return compared to usual care. And that usual care is care on general medical wards. And the reason is because when you have a stroke, you have the central part of the artery which is affected. So that part is damaged. So that's not going to come back. But the surrounding area, which is called penumbra, you can salvage that. So the aim in acute stroke is to salvage the penumbra, okay? The ischemic penumbra, the area at risk. Core is damaged. Nothing can be done about it. So very important that we understand this. Last slide, when you suspect a stroke, check face, check arm weakness, speech problem, test all 3, call 999. This patient has suddenly altered speech and right arm is weak. Is this a stroke? Yes, my answer is yes, until proved otherwise. Should immediately be taken to hospital and managed and have CT scan and urgent assessment. Thank you very much. And I will hand over to my colleague.
Thank you very much, Naseem. That was really wonderful. I think, Naseem, I just have to kind of actually let you know, I did get a WhatsApp message from our colleague, Dr. Yawar Saeed. Unfortunately, as we all must have thought that as medics, we are bound to respond to emergencies. And Dr. Saeed was actually on call today, and he just texted me back. He's apologized, but he's happy to sort of go through some of the slides that he's really prepared very hard for all of you. So Naseem, if you could just find out if Dr. Saeed is actually on with us, because he is quite keen to present, and he's apologized profusely that because of his on-call, he had to respond to the emergency. So I know a lot of you would have actually been here to listen to his talk on ECGs. He's got really interesting ECGs on arrhythmias. Maybe not for a 20-25 minutes presentation, but if we can actually allow him to sort of talk for the next 5-10 minutes. If everyone's okay, could I just see a thumbs up, please, if that's all right, if we can allow Dr. Saeed to present. Yes, I can see Dr. Naseem Thomas, you're okay with that. Tahira, you're fine with that? Thank you. So yes, a lot of people saying in the chat, Fatma Zain, thank you very much, Anne, thank you. So yes, I'm just waiting for Dr. Saeed to log in, and then we will have his presentation shortly.
In the meantime, guys, do you have any questions for myself or Dr. Shakir?
Yes, please. If you could just actually ask any questions. I think Naseem, you've had a wonderful presentation. Any questions for Dr. Shakir or Dr. Naqvi, please?
Okay, so there is.
There was hardly any question. Dr. Shakir, would you? Naseem, there's a question for you. I'm really sorry. Please, can you tell once again what's the difference between TACs and PACs, please?
Okay, yes, sure. So the TACs is when you have all three: higher cortical dysfunction, which is dysphagia, apraxia, and all those things, and unilateral weakness, which means arm weakness, leg weakness, or both arm and leg weakness, and homonymous hemianopia, which means for the right eye, right temporal and left nasal field gone, and for the left eye, left temporal, right nasal. When you have all three present, you have TACS, total anterior circulation syndrome. Now, when you do a CT scan and you see a big infarct, then the TACS becomes tachy. So that you initially you put in the medical clerking, diagnosis TACS, CT brain, etc., nil by mouth, IV fluids, and then when you've done the CT and it shows the infarct, then the TACS becomes tachy, total anterior circulation infarct. For PACS, partial anterior circulation syndrome, you have any two of the three present, but not all three. So any two of the three. So either a homonymous hemianopia, or higher cortical dysfunction, or unilateral weakness. Okay.
Naseem, Andrew is asking the same. I mean, essentially the same question: is the visual defect and limb weakness on the same side?
Yeah, absolutely. Absolutely, because then it won't, otherwise something else is going on. So the right-sided brain infarct will give you left-sided weakness, okay? And in the visual field loss, you will see, as I explained earlier, left eye temporal field loss and right-sided nasal.
Okay, I think.
Okay, so very, very important. So right-sided brain infarct in the right parieto-temporal or frontal region will give you left arm and leg weakness, and in the left eye, temporal side is affected, and the right-sided nasal. So that explains visual field, and so yes, absolutely.
Thank you very much. Without wasting much time, actually, if you've got any more questions, please, if you just put it in the chat box. I've got Dr. Yawar Saeed who's joined us now. Yawar, can you hear me? If you could just start, Naseem, could you just make Yawar the host, and could you please help him with sharing the slides, please?
Yeah, sure. Okay, Yawar is the host now.
Yes, Yawar, you are the host now. Please do introduce yourself and please share your PowerPoint presentation. Thank you.
Hello, Assalamu alaikum. Good afternoon. Sorry, I was asked to rush to the hospital. I'm really sorry about being late. I'm Dr. Yawar Saeed. I'm one of the cardiologists and electrophysiologists here at Aga University Hospital in Karachi, Pakistan. Though trained in England, and then obviously I went on to Canada for my electrophysiology training. I also happens to have a PhD in cardiovascular sciences from University of Manchester. So I'm not sure how long I have. Mansoor.
Yeah, you can have as much as you want, but I think I'll probably, for the benefit of everyone, maybe 10-15 minutes, so we can condense your 25 minutes presentation to 10-15 minutes. Salient point, anything that you feel is actually relevant to the audience.
Yeah, so give me just 2 minutes, and then obviously I'll open the talk. Okay.
Yawar, I've made you the host, so you can, if you can share your screen if you want.
1 minute. Okay.
Thank you. We can see your screen now, Yawar.
Okay.
Yes, we can see.
So I'll just go quickly. I think for simplicity's sake, I've obviously I made this obviously very simple. Plus, please stop me in the middle if you did not understand anything. But I'll go quickly just to discuss a few important points. Obviously, I think they are all very learned people here. So so when we talk about arrhythmia, obviously all of you will understand that obviously there is bradyarrhythmias and tachyarrhythmias. But what have been traditionally being taught is to understand arrhythmia in terms of here I wanted to give you just an overview to assess arrhythmia duration is. So a tachyarrhythmia with obviously you know the heart rate is more than 100 beats per minute, but what I want you guys to do is to differentiate arrhythmias on the basis of narrow complex arrhythmias in terms of QRS duration. If they are the QRS duration is less than 120 milliseconds, or the QRS duration is more than 120 milliseconds on obviously, or more than 3 small squares on the ECG strips at 25 millimeters per second. And same as you go with bradyarrhythmias. The reason when they are narrow complex, you have time. You have time to act, you have time to differentiate what it is. But when the arrhythmias is brought complex, you need quick decisions to stop the patients from deteriorating. And then arrhythmias, the heart rate of between 60 to 100 beats per minute. The most common one, as we know, is atrial fibrillation, which is rate control. Now, in terms of tachyarrhythmia, I think when you look at the narrow complex tachycardia, always these are the 5 differentials. And for obviously for general medicine and even for cardiology sakes, I think these differential diagnoses actually suffice to get an understanding of how you can manage the arrhythmias. So if you remember these 5 differential diagnoses, AV nodal reentry, we will discuss about AV reentry tachycardia quickly as well. But these 5 differential diagnoses will make you understand how to treat these patients in an emergency situation and then to refer. So these narrow complex tachycardia, differential means atrial tachycardia, atrial fibrillation, flutter, AV nodal reentry tachycardia, and then obviously AVRT and sinus. Now, if you look at this ECG, obviously, what again, if I want you to see is make this very simple. So is this a tachycardia or bradycardia? As you can all see that this is obviously a tachycardia, and it's completely irregular. And the first differential that obviously that comes to mind, that this is obviously atrial fibrillation, but I always tell my juniors and fellow colleagues, always have a differential diagnosis in mind. So what else it could be? So whenever you have a completely irregular, narrow complex tachycardia, always make sure that the differential, other differentials other than atrial fibrillation could be multifocal atrial tachycardia and atrial flutter with a variable block. And here, obviously, if you see in some of the lead, this is completely irregular rhythm. There is no P waves at the baseline, or very difficult to see P waves, and this is atrial fibrillation. Now, atrial fibrillation, as we know, is a very common abnormality in about 15% of hospital admission, according to one study, has got atrial fibrillation, which is obviously a very high percentage. And no matter whatever specialty you are in, you will see atrial fibrillation. Whether you are surgery, medicine, obviously it's very common. Gynae, you will see atrial fibrillation, which is as common. And traditionally, we tend to divide atrial fibrillation into these 3 categories. Paroxysmal atrial fibrillation, the atrial fibrillation then comes and goes. Persistent atrial fibrillation, obviously, is the atrial fibrillation that lasts for more than 7 days. So the diagnosis is any atrial fibrillation of less than 7 days duration, and the atrial fibrillation which comes and goes is paroxysmal or episodic. And persistent atrial fibrillation, any atrial fibrillation that lasts for more than 7 days. Atrial fibrillation is the one when we decide or agree that yes, we are going to accept that we accept the rate control in this patient. Then we call it permanent or chronic atrial fibrillation. The chronic atrial fibrillation, I would not like to call any atrial fibrillation chronic, because the chronic atrial fibrillation does not give you an idea of what you are doing with it. In terms of paroxysmal or persistent atrial fibrillation, you are going for a rhythm control strategy, and in permanent atrial fibrillation, you are going for a rate control strategy. Now, what is rhythm control and rate control means, and what does it do to the choice of the medication that we use? So rate control is when you are obviously using medications like calcium channel blockers, to some extent beta blockers, and obviously the digoxin is now making a comeback as well in some patients. So whenever you're going for a rate control, you are looking or you're thinking about these drugs. But when you are going for a rhythm control strategy in which you wanted to stop the episodes of atrial fibrillation happening, then you are looking for drugs like amiodarone, flecainide, sotalol, So sodium channel blockers and potassium channel blockers primarily. So these are propafenone, are the other medications. So here you make a clear distinction when you call somebody paroxysmal atrial fibrillation, because then you are committing yourself that you are going to go for a rhythm control strategy. But obviously, when you are calling someone with persistent atrial fibrillation, long-term persistent atrial fibrillation, or permanent atrial fibrillation, then you have decided that you are not going for a rhythm control and you are going for a rate control strategy in this group. Anticoagulation is extremely important in this in atrial fibrillation, as we all know that atrial fibrillation can cause strokes, and the stroke category varies. The recent guidelines which has come out, the ESC guidelines, have stressed pretty important distinction that you'd always do a Church-Vasquez score in this population and who has atrial fibrillation. And anyone with a CHARS score of more than 2 should be anticoagulated. Now, the distinction here has to be made in patients who are females. So female patients already, if they have any other risk factors, automatically have a risk score of more than 2. So you have to make a distinction. So the distinction is, if the patient is a female, then only being a female does not makes him an automatic choice for anticoagulation. Has to have 2 other risk factors. But for male category, obviously, the male, then you can have patients who have a 2 risk score, which is hypertension and congestive heart failure, or age of more than 65 years, or age of or any vascular risk factors, including this category. So remember, if any patient with a Church-Vasquez score of more than 2 should be anticoagulated. In females, it should, including the female risk score, if the Church-Vasquez score is more than 3, should be anticoagulated. Now, the question is what you would do if the patient has a risk score of more than 1. And this distinction is important, especially in patients who have got South Asian or Southeast Asian category. And this distinction has been very clearly documented, and Asia Pacific Heart Rhythm Society makes this distinction very clear. Any patient with a South Asian or Southeast Asian descent should be anticoagulated. So those who have got Southeast Asian population, they should be anticoagulated if the Church-Vasquez score is more than 1. And even in patients with a European descent, it should be considered anticoagulation with the new oral anticoagulants. Always accumulate the Has blood score in this population. If Has blood score should not stop us from anticoagulating patient, but it actually is a score to guide us that these patients are at risk of bleeding, and we should assess this and correct the risk of bleeding, rather than just making a blanket statement that Has blood score is 3 or more, so we cannot anticoagulate. So that's very important in this patient population. This, I think, is very important, and it comes up in questions quite often, that what we'll do if somebody has come in with a sepsis and has atrial fibrillation. What will happen if somebody's come in, let's say, with an acute myocardial function like anestemia and has atrial fibrillation. And this is important. Atrial fibrillation, unfortunately, is not something that will go away. And these patients should be very carefully followed up, because these patients in the future have a very high chance of developing atrial fibrillation. And they are almost always associated with adverse outcome. There's numerous studies. I only mentioned one study here from Waki et al. From chest, but there are multiple studies which have shown that atrial fibrillation per se, even in patients who are post-operative, if they develop atrial fibrillation, almost 50% of them go on and develop atrial fibrillation in the future, in the 5 years time. And so that's important, that atrial fibrillation, if it's happened in sepsis, is not going to go away. You have to follow these patients up very carefully monitor them for development of atrial fibrillation, and keep them on anticoagulation at least for 6 weeks to 3 months post-discharge to make sure that they are not developing atrial fibrillation. What to do in cases if you have sepsis-induced atrial fibrillation? And always I feel that it is, we obviously are, when we see atrial fibrillation, even though it's happening in sepsis, there is some knee-jerk reaction of treating this with digoxin and beta blockers. And remember, atrial fibrillation is usually, in sepsis, is usually the result of the sepsis. And so what happens and what you would do, so my question to most of my colleagues is, what you would do if you have a sinus tachycardia in sepsis? You are not going to go on and treat it. So unless atrial fibrillation is very fast and you feel that it is affecting the hemodynamic of the patient, then yes, treat it. But otherwise, if you treat the sepsis with antibiotics, fluids, usually the atrial fibrillation rate comes down. So that's important as well. Other thing is, if the patient comes to you in sepsis situations, can we use amiodarone to cardiovert patient? And I really think that this is not a very good idea for two reasons. One, obviously, is these patients are, you don't know when the atrial fibrillation started, first. Second, these patients are procoagulant, so they are in an hypercoagulable states, and converting them back into sinus rhythm with amiodarone can result in strokes. And second, if you use amiodarone, these patients obviously have other electrolyte imbalance, so they are at risk of a long QT interval and then dorsal. So please don't use amiodarone, especially in patients with overwhelming sepsis. And because obviously for this reason that you don't know when the atrial fibrillation starts. You can use, if you are really pushed, then obviously I think you can use metoprolol, you can use digoxin. Amiodarone use, obviously keep it to a minimum and leave it for your cardiology colleague to advise you on it. And make sure that whenever you start patients on amiodarone, their QT intervals are I think we have discussed this and think we should go on very clearly now. This is another ECG for you guys to look at. And this ECG, as you can see, again, if you see it, you if you describe what you see, this is a narrow complex tachycardia with a rate of more than 240 beats per minute. And here the differential diagnosis is very simple in a way that is either AV nodal reentry tachycardia, AV reentry tachycardia, or atrial flutter with a variable block, or atrial tachycardia. And the distinction here, if you guys have a look more carefully, in patients with a narrow complex tachycardia, we always look for a pseudo R pattern or a pseudo S pattern. So pseudo R is actually the retrograde P waves that we see in AV nodal reentry tachycardia. And if you see my mouse, if all of you can see my mouse here, if you look very carefully, you may see a little squiggle in lead 2 just after the QRS complex. And this little squiggle just after the QRS complex, you can see these are the pseudo S waves, especially I think in lead 3, I think it's more reasonably seen on these signs. So these pseudo S waves tell us that this is an AV nodal reentry tachycardia. The reason is that the circuit of AV nodal reentry tachycardia is very short. It's within the AV node, and at the same time that it is giving a QRS complex, it's also giving a P wave. And that's why the QRS complex and the retrograde P waves happens at the same time, which obviously comes out as the retrograde P wave just after the QRS complex. So this is sometimes guide you that this is AV nodal tachycardia. But obviously, for all practical purposes, this is a narrow complex tachycardia with a normal axis with a rate of more than 250 beats per minute, and we have to do something about it to get rid of it. So the management is quite simple. I think vagal maneuvers is always forget this, that there's something which is very simple. If you I think maybe about 4 to 5 years ago, one video comes around on YouTube from a Brazilian emergency department, in which a patient was blowing in a syringe, and at the same time we can lifting the leg, and it's terminated. This is actually getting very popular in emergency room settings because it's actually terminate the tachycardia more than 90% of the time. That if you ask the patient to blow in a syringe as hard as he can, or he or she can, and at the same time somebody can lift the legs, it actually results in a termination of the tachycardia. The other vagal maneuvers, as we know, is Valsalva maneuver, and it's always very difficult to tell the patient how to do the Valsalva maneuver when they have these narrow complex tachycardia. And a simple way is the same movement as they do when they are obviously passing the stools. So if you just tell them to do the same movement and keep the pressure on for about 2 minutes and then suddenly let go, this is obviously an easy way to tell the patient. Adenosine. So yes, adenosine, again, when we give adenosine, always this is the only medication you give very quickly, and followed it up with a very big flush of about 20 mils of saline, because the adenosine, yes. Yeah, I'm just going to go to the narrow complex tachycardia, and I think I'll stop, and then probably we come at another time. So adenosine is give it very quickly, and then the only medication. Please do not give other medication, especially not amiodarone, very quickly. Give it very slowly. Then correct the other electrolyte abnormalities. Sometimes you have incessant supraventricular tachycardias in patients who have got CKD or on dialysis, and make sure you correct the electrolyte abnormalities in these patients. And the narrow complex tachycardia patients are the one who are actually can be ablated very successfully. So these all should be referred for the electrophysiologically for ablation. This is again an ECG, just for you guys to see it. Is as you can see, if you look at the QRS duration, it's not very clear, but definitely more than 120 milliseconds. So this is a broad complex tachycardia with a rate of about 150 beats per minute. Almost always, the broad complex tachycardia is a ventricular tachycardia until proven otherwise. Do not try to differentiate this between supraventricular tachycardia with bundle branch aberrancy, a mistake that has happened very commonly. So remember, all broad complex tachycardia are ventricular tachycardia until proven otherwise. In this ECG, if you look at the rhythm strip at the bottom of the screen, you see that these are an narrow QRS, broad QRS complex. But in the broad QRS complex, I would like to draw your attention to these little squiggles. You can all see my mouse, guys? Mm-hmm. Yes, so if just look at these squiggles, which you see here, then you see it here, obviously, then you see another one here. These are actually the P waves, which you can see, and these are happening at regular intervals. So this is atrioventricular dissociation, which is a hallmark of ventricular tachycardia. The other thing is, if you see that this is right bundle branch block pattern, with V1 being positive in lead 1, V1, and this right bundle branch block pattern tells you that this rhythm is being originated in the left ventricle. So same as Naseem was talking earlier about the right side stroke causing left-sided weakness. Similar on the ECG, if you have a right bundle branch block on the ECG, the origin of a tachycardia, that is a ventricular tachycardia, happens to be on the left side. The reason, the V1 is a right-sided lead, okay, which is on the right side of the chest. And if you depolarize the left ventricle, which is obviously on the left side, the electrical forces travels from left to right. And by ECG, if a electrical wave of depolarization is coming towards the lead, it will be positive. Okay. So same principle actually so applies. So if you see here, this is what's happening. So this is a tachycardia which is originating in the left ventricle. You have AV dissociation here on the ECG, especially on the rhythm strip, and this is a VT. But all broad complex tachycardia are ventricular tachycardia until proven otherwise. This is another ECG. Again, if you see on this one, again, a broad complex tachycardia, left bundle branch block pattern, V1 is downwards. You have left axis deviation here. Here it's very difficult to see the P wave in this one. So you will still call this ventricular tachycardia again until proven otherwise, because it's difficult to see. And if the, so statistically speaking, if you see a broad complex tachycardia, and I'll tell you the patient is hemodynamically unstable, if you don't look at the ECG and say it's VT, you will be right about 80% of the time. If I'll tell you that this is a broad complex tachycardia in somebody who is hemodynamically unstable and had a very poor left ventricular systolic dysfunction, then you will be right 90% of the time. Okay, but if I add another thing, that this patient with a broad complex tachycardia, which is hemodynamically unstable, had poor left ventricular systolic dysfunction, also happens to have a myocardial infarction. Again, if you don't look at the ECG, I don't recommend it, but even if you don't look at the ECG, you will be right 95% of the time. So this is how common a broad complex tachycardia can be VT. So these are the differential diagnoses of a broad complex tachycardia. And remember, the ventricular tachycardia comes as a very frequent one, which is about 80%. And then you have left SVT with evidence in 15 to 20%. We have some interesting ECG for you to look at, but I'll stop here just for the sake of time.
Thank you very much, Yawa. I think that was much appreciated, being on call, but still able to give us at least about 20, 25 minutes talk on tachyarrhythmia, especially atrial fibrillation and narrow complex tachycardia. I think it's really, really appreciated. I'm sure all of us here have actually learned a lot about this. Let me just ask the audience if they've got any question. I'm moderating the chat. There's no question, but just a question from me, Yawa, about
I've just muted you. Mansoor, yeah, sorry, go ahead.
Okay, yeah. So, Yawa, the question is about narrow complex tachycardia. I've had a patient, a transplant patient, had a failing transplant function on dialysis, had gone into SVT a few weeks ago, actually on the ward. The juniors on the ward, we had no registrar, so I was just finished my ward round. I had to sort of actually do the same maneuvers. He said the valve servo blowing into the syringe did not sort of revert him. He did have an AF a day before, because we had to put a line into him to facilitate dialysis. I think the line could have actually caused some problems, so we did give him some bisoprolol a day, 24 hours before the event. Then he went into SVT. I had to kind of actually give him some adenosine. Obviously, everything was okay in terms of his electrolyte abnormalities. And then literally within a minute or so, did go into sort of sinus rhythm. Just a question about adenosine. Could you tell us actually how safe is it to be given on the ward? Do you need to have the patient to be on CCU, or do you have to have a crash trolley next to the patient? Also, if a patient is mildly asthmatic, which my patient was, but really controlled asthma, I still dared to give him some adenosine. So just some sort of practical points about.
So yes,
Yeah,
Naseem, yes, so adenosine, yes, it can be given in the ward as long as you have a monitor and a crash trolley there, because sometimes the adenosine can cause a bradycardia of a sponsor for about 60 seconds. It can be given in asthmatics as long as they are well controlled and not having an asthma attack at the time, just because the adenosine half-life is very short, about 2 to 3 seconds. So rarely, to be honest, there is no real contraindication to not to give adenosine. But obviously, it makes the patient quite unwell, especially if the patients are asthmatic and have sinus tachycardia. Sometimes, unfortunately, happen in some patients that they are actually having sinus tachycardia. People perceive that, oh, this is SVT. They are actually asthmatic patient having an asthma attack and sinus tachycardia with it, and was given adenosine. And you're right, in dialysis patient, because of these changes, the SVTs are pretty common. And sometimes obviously you have to give them in the ward. As long as you have a crash trolley, it's perfectly safe to give it.
Thank you very much. Yeah, well, that was an amazing talk. Naseem, thank you very much for stepping up. And so Dr. Anila Minshaka's talk. I think we have actually exceeded about 10, 15 minutes from a slotted time. I know everyone actually has other commitments as well. It's a Sunday evening. So thank you, everyone. Thank you very much. I have looked at the chat. There was
one comment about the
apart from what was said before, but yeah, go on, Naseem.
Just one comment, guys. The certificate, I hope you're able to access it. It's please copy and paste the URL link that I've shared in the chat in some browser, and you should be able to open it. Okay. So just to repeat, the URL link will take you to the your CPD certificate, but you have to copy and paste it in a browser, not from the Zoom directly. Okay. So I hope you're able to.
And also, just to let you know that we will be back in December. We will send you the details of the link, and it will be sort of a Christmas quiz or pre-Christmas quiz in December. But we'll definitely send you the link, and we'll let you know which Sunday. It's between me and Dr. Naseem that we will decide on that, and we'll let you know. But thank you very much, everyone, for your patience, for attending, and keep going and keep listening to our webinars. Thank you very much. Thank you.
Thank you, Mansoor. Bye-bye.